Uh, Good morning, good evening, good afternoon, people who are joining us from all parts of the world. We welcome you to this very, very important webinar that we are hosting to discuss around elimination for neglected diseases. So we want to just have this webinar. The title of this webinar today is Unite to Eliminate, Bridging Gaps in Treatment for NTDs. And so we're very excited that you are joining us to discuss this very, very important topic about elimination. We are just 6 days away from marking the 5th World NTD Day, which is such an important day for raising awareness on neglected diseases, but also having discussions and crucial platform to discuss critical factors that impact the fight against neglected diseases. And this webinar has been organized by Médecins, Frontières, MSF, together with Drugs for Neglected Diseases Initiative, just partnering and collaborating together to just speak around elimination. My name is Lynette Otieno. I'm a head of communications, and I'm glad to be your moderator today. Before we move on, we just want to share some housekeeping issues so that as we continue the discussions, you're just aware about these housekeeping issues. The first one is, we would like, for those who have joined us, as we continue the discussions, we would like that if you have a question, please type it in the chat and we will try to answer it at the end of this particular webinar. We would also request the speakers that you turn off, you mute your audio until it is your time to speak. So kindly mute your audio so that there's no interruption, and remember to unmute yourself when you are speaking. Finally, if you would like to share this conversation online, you'd like to follow it, please post on any social media. The hashtags are end the neglect, hashtag end the neglect, hashtag beat NTDs, and hashtag end NTDs. And feel free to tag DNDi and MSF East Africa. So we want to start with the basics. For those who might have joined us and they don't know what neglected tropical diseases are, this is a group of chronic debilitating diseases that affect over 1 billion people worldwide. If you go to the WHO website, there are about 20 of them that are listed there. They are found in the most poorest and marginalized community. The most vulnerable are the ones that are affected most by these diseases. They are preventable and treatable, but due to significant gaps in access and innovation and other factors like poverty, lack of awareness, inadequate infrastructure, they continue to affect people. And so this is why they're still an issue because of just these particular issues that I've mentioned. Just looking at the progress we have made so far, in 2021, WHO launched a roadmap for neglected tropical diseases that sets out global targets to prevent, control, eliminate, and eradicate a diverse set of neglected diseases by 2030. One of the main targets is that to have 100 countries achieving elimination of at least one NTD as a public health problem by 2030. So far, there's been some progress because 50 countries globally have eliminated at least one neglected disease, and this includes 19 countries in the African region eliminating one NTD as a public health problem. So we are in the cusp of elimination.
Recording stopped.
Celebrating a lot of headway, but there are still challenges and gaps. And this is why we are having this discussion today. And so today we have set out and set for you and brought to you a formidable group of speakers and experts, 3 of them, who will highlight from their practical experience, experience in innovation, working with governments and other stakeholders, how we can unite to eliminate neglected tropical diseases. So I want to begin by just introducing them, and then we can go into just the crux of this topic. I'm hoping that we can engage you and you shall, sink into this discussion and see how we can work together to eliminate this disease. Our first speaker is Dr. Margriet Den Boer, who is an NTD advisor at MSF. She has over 15 years of experience with MSF, the WHO, and has also worked for Drugs for Neglected Diseases Initiative, working on access to care for visceral leishmaniasis at all levels, from the producer to the patient. And she has published extensively on this topic. She was a regional coordinator for Africa for the implementation of Calaco Consortium program from 2014 to 2019. And she has also collaborated in and led operational clinical research for visceral leishmaniasis performed by MSF. So Dr. Den Boer, Dr. Margriet, welcome to the panel. You can just say hello, and then we can move on to the...
Hello, everyone. Thank you, Lynette, for your introduction.
Okay. So our second speaker is Professor Sam Kariuki, who is the Eastern Africa Director for DNDi. He was a former acting Director General for the Kenya Medical Research Institute, which is one of DNDi's founding partner. He's a fellow of the Africa Academy of Sciences, an honorary faculty member of the Wellcome Sanja Institute, a visiting professor of tropical microbiology at Nuffield Department of Medicine, University of Oxford, UK, and a member of the American Society of Microbiology. He also serves as a member of the WHO Strategic Advisory Group on Antimicrobial Resistance. Welcome, Professor Sam. You can say hello. Then you can move to...
Hello, everyone, and very, very nice to be here in this forum.
Thank you very much. We want to move over to Simon Bolo, who is currently the head of Leishmaniasis Access for DNDi in Eastern Africa, leading the program whose goal is to facilitate the uptake and adoption of optimal treatment options for Leishmaniasis patients in the region. Before this, he headed the operations portfolio at DNDi. He has over 20 years of experience in operational management, progressively gained in private and the non-profit sector. He's also an active member of the Leishmaniasis East Africa platform, which supports clinical assessment of improved treatment for Leishmaniasis, as well as strengthen clinical research capacity and improve access to treatments in the region. So welcome, Simon.
Thank you very much, Lynette. Hello, everyone. Glad to be here and engage with you.
Thank you. So we want to just delve into this important topic by starting with the basics. And would like to ask Professor Sam to just answer for us this question. Who is the most affected by neglected diseases? And why have there been gaps of innovation for tools, particularly for treatment?
Thank you very much, Lynette, for that very, very important question. Now, when you look at our societies where neglected diseases are endemic, you find that the most neglected of the populations in each of these endemic areas are the most affected for a number of reasons. One is that according to definitions, actually NTDs are a real disease mainly for poverty because these are populations that don't have a voice. Sometimes when they get sick, they are not able to attend to medical care immediately. And very, very few organizations are investing in access to be able to reach these very vulnerable populations. So in summary, these are diseases of poverty and with very little, I would say, of a voice to the people who are affected. And we have a history over a long period of time of very little investment, either by governments or even by other organizations that would otherwise benefit these populations. In every community, sometimes people who have no voice are easily forgotten until somebody comes over to be able to help them. And that's why DNDi, MSF, and other organizations come together to fight NTDs. Thank you.
Thank you very much. I think just that aspect of being neglected and them being voiceless really stands out. And we have to work together to give them a voice. Yeah. Thank you for that, Professor Sam. So I'd like to invite Margaret to respond to this second question. In East Africa, particularly Ethiopia, South Sudan, and Sudan, vulnerable communities face multiple neglected diseases such as snake bites and visceral leishmaniasis, which is commonly known as Kala-Azar. How do these entities uniquely impact these communities? And please brief us on what MSF has been doing to address both prevention and treatment, particularly for Kala-Azar. You are unmuted? Okay.
Yeah, thank you for your question. Of course, there's a lot to say about that, but I will try to keep it short. Maybe I will focus on the disease visceral leishmaniasis, or also called Kala-Azar, which is a disease that MSF has been working in for the last 30 to 40 years. We have treated over 150,000 patients in total. We started with this disease treatment in the 80s because there was an epidemic in South Sudan that was undiscovered for a long time. Finally, MSF was able to identify what disease was ravaging the communities there. We started treating people, and we did later on a study that showed that over 100,000 people had died from Kala-Azar. Just to explain to you all what is Kala-Azar, it is a parasitic disease in symptoms quite similar to malaria, and it is fatal when it is not treated. It's transmitted by an insect called sandfly, and it predominantly affects the poorest of the poorest people, people without adequate housing, people on the road who are refugees, and people who spend a lot of time in proximity to the vector, the sandfly, so outside harvesting, being in forests, etc. So now there is much more attention for this disease, and WHO has even put it on a roadmap for elimination. But we are still quite far away from that. The problem is mostly that it is difficult to access the patients because they live in remote areas. They're very poor. They don't have often the money to come to the clinics to be treated. Health education does not always reach them. So they are neglected populations suffering from neglected diseases. Thank you.
Thank you very much, Margaret. You can also just maybe speak to what MSF has been doing to respond to these patients who are affected by this disease. Yeah.
Yes, since we identified the disease in South Sudan in the 80s, we have progressed with operations in almost all East African countries to address Kala-Azar. So we are also active in, we have been and we are active in Ethiopia, Sudan. We have worked in Somalia, Kenya, Uganda. And in total, we've treated over 150,000 patients. Our role has been to provide access to treatment. So we go to difficult to access locations, often in conflict areas, and try to reach patients there. We provide diagnosis, treatment, health education. Unfortunately, there's not many ways in which you can prevent getting infected, but whatever ways there are, we try also to implement them.
Thank you. Glad that you're saying that there's now a focus to eliminate leishmaniasis. You know, there's a focus on it, and I think last year there was the WHO brought together various stakeholders to discuss how this region can eliminate leishmaniasis, because it's this region has the highest number of patients with leishmaniasis. So just before we move to the next question, I would want to just recognize all the participants from various parts of Africa. I'm seeing people from Ethiopia, from Somalia, from Somaliland, from South Sudan, from Uganda. You're all welcome. And thank you for keeping the chat alive. So my next question goes to Simon. Would like to know, how is DNDi bridging treatment gaps? Just focusing on your field experience for the neglected diseases that DNDi is addressing. How is DNDi bridging this gap of treatment?
Thank you very much, Lynette, for that question. Maybe just to take us back a little bit, as we all know, DNDi is a research and development organization. So what we've been doing is developing new treatments or improved treatment for the neglected diseases. But at some point, we came to realize that developing the treatments alone was not enough, because we needed to get them to the patients, which was not happening at a given point in time. Given that our mandate is to improve the quality of life of neglected patients, then we embarked on what we are calling the Access Program. And in our Access Program, our main aim is to accelerate treatment to patients, both treatments and diagnostics. And we are using an internally developed framework which has 4 key dimensions of demand, supply, financing, and structural obstacles. So what we're trying to do is to see how to eliminate the obstacles that exist between the drug and the patient that makes it difficult for them to access them on time. So as an example, on the demand side, we are looking at test and treat options that are lacking, especially in some of our disease areas that you are working in. There's poor health thinking behavior, long policy change processes to ensure that these new treatments are included in the treatment guidelines. On the supply side, most of our neglected tropical diseases products have single manufacturers, so makes procurement very difficult. The supply chain management as well is a bit laborious. We've had situations where we've had stockouts because of the long supply chain processes that we are engaging in our different countries where we work in. And this, in some cases, has caused health workers to maintain patients for as long as even 3 months as they wait for the drugs to come on board for treatment. Stockout is a key challenge that we are faced with currently, especially in the leishmaniasis program that Margarita has just talked about. And on the financing side, we've been depending quite a lot on donor funding. So these are some of the issues that we're trying to see on how to address to make sure that we eliminate the obstacles that we are faced with. And finally, on the structural obstacles pillar, we work on trying to address issues such as patients coming from far, as Margarita has mentioned. And then this, what we've been trying to do is expand treatment closer to patients. We have examples that has made this a very successful initiative, where in both Uganda and Tanzania and in Kenya, we've been able to expand treatment much closer to the patients, reducing the commute time and, of course, the cost of transport of the patients to the hospital. Specifically in Kenya, we've been working in a region called West Pokot, specifically at Kachaliba Hospital, and we realized that majority of patients, nearly about 20 to 30%, were coming from a region called Sigor. So together with the Ministry of Health and various partners, we were able to assess this new treatment, a treatment center closer to the patient, and we've been able to set up a new treatment facility there. Currently, we're in the process of developing, or rather building, a ward to be able to deal with the many patients that are being seen in that area. Other than that, what DNDi has also done is build partnerships because we've realized that working together is very important in eliminating the disease. We've also been trying to see on how to respond to the needs of the public health priorities in the region. So the ministries of health, we work very closely with them to ensure that their priorities are aligned to what we do, and then we are able to support them in achieving the same. But most importantly, as we all know, DNDi develops new treatments, and we've been able to come up with a first oral treatment, which is called miltefosine in combination with paramomycin, which currently is in the process of being recommended by WHO as a new treatment for VL in the region. This is going to change how we treat our patients, because the duration of treatment is reducing to 14. It is much more effective treatment, and it is better tolerated by children. So in a nutshell, that is what we are trying to do as DNDi in accelerating treatment to patients. Thank you.
Thank you very, very much, Simon. Very crucial points there, because for us to achieve elimination, we must achieve access to the tools that will be able to treat patients. And you've spoken about some of the challenges of supply chain, and hopefully in your next question you can address how you feel that those challenges can be addressed so that patients can access the treatments and the tools that they need. Yeah. So thank you for that. Please continue. I'm seeing some very excellent questions on the chat. Please continue just asking your questions, and we will try to answer them. We might not answer all of them, but we will attempt and do our best to do so. Just changing the tune a little bit, just to focus on now what next. We have spoken about what the challenges are, what we have been doing as various institutions and partners, and now we want to just look ahead and look at how we can achieve this target of elimination of diseases, of such diseases as leishmaniasis by 2030. And so the next question will go to Marguerite. As we strive to eliminate neglected diseases, what are some of the key gaps that we need to consider? Kindly answer that. Yeah.
Thank you for your question. From MSF perspective, the most significant barrier to elimination of CALASR is to get access to the patients. Currently, we are not even exactly sure what is the burden in the remote areas. So we don't know even exactly what we are talking about when we want to eliminate the disease. I think one important point to mention is that the treatments that DNDi has been testing and that are now available are offering an opportunity to come closer to the patients. CALASR normally is only treated in tertiary hospitals, secondary or tertiary hospitals, where the patient needs to stay in the hospital due to the length and the toxicity of the treatment. The treatment that DNDi is now launching it can also be done in more basic health care facilities, and so that means that we can decentralize treatment, and that will make it much more easy to reach patients. I think another barrier is that CALASR it is a neglected disease. It's neglected also in terms of funding. Donors have not been very generous with CALASR in East Africa, and we need a big step up in funding to realize elimination. It is going to be a very large investment, but a very rewarding investment as well, because many deaths can be prevented in that way. So hopefully we will all be able to come together and advocate for more funding for CALASR control programs in East Africa. And a third barrier is that because it's such a neglected disease, there has not been a lot of research and development. Apart from DNDi, other organizations are not doing that much, and we really need to step up in order to make new molecules, new diagnostic tests available to be able to decentralize the treatment even further, and also to be able to come up with ways to prevent getting the infection in the first place. In MSF, we are mostly, as I said, investing in creating access to treatments. For the rest, we are also, with our sort of centers of excellence that we created in the countries, we are able to pilot implementation of new treatments. And we do a lot of advocacy. And also we are assisting governments, WHO, with the technical knowledge that we have built up over the years. Thank you.
Thank you. Those are very important points. Very aware that over the past years, there has been a reduction of funding, which is unfortunate because we really do need funding to reach the last mile, because we are on the cusp of, getting treatments, elimination. So we really do need funding to really reach that last mile. And so they're calling on, partners and funders to really support this because once it's eliminated, then we can move to the next thing, but we need funding for that last mile. So thank you for very, very crucial points on some of the gaps that we need to think about. I'd like to just ask the next question to Sam. There are things that we cannot ignore when we are thinking about access to treatments, access to tools, prevention, control, and elimination of neglected diseases. And one of the things that we cannot ignore is issues of climate change and conflict, because as we make progress towards elimination of NTDs, there are emerging challenges such as climate change and conflict that threaten to derail this crucial effort. In light of these obstacles, what do you feel are the key adjustments and innovative approaches that we should consider to ensure that we stay on track for elimination in the next few years? Over to you, Sam.
Thank you, Lynette. It's a very, very important question. And I think all of us in the audience here are very much aware about climate change as pertaining to the political establishment. This is one of the bywords that has been going around many, many times with reference to how it's affecting economies and so forth. But for us, much more important is that climate change, especially changes in weather patterns, affecting vectors of key neglected tropical diseases is going to change the paradigm in terms of the epidemiology of these neglected diseases. For instance, a few years ago, actually 2 years ago, we realized that we have new vectors for a type of malaria. This is a vector called Anopheles stephani that usually is very prominent in Southeast Asia. And then it was first observed in Kenya about a year or so ago, and very new, but very efficient in transmitting malaria in urban areas. So a new paradigm for which we're ill prepared. Another example is, of course, the changing pattern of multiplication of sandflies because of changes in weather patterns, of course, climate change in general, and that brings these vectors to areas that they were not found before. And in the last 1 year, Kemri and partners have been able to establish that there are new pockets of Kalaza, new pockets of visceral leishmaniasis in places as far as Kajiado that never used to record this kind of cases, all because there's been a change in the ecosystem that sustains the multiplication of sandflies, which are the main vectors of this disease. Another example, just to illustrate this point in terms of how climate change is affecting the paradigm on infectious diseases, but particularly NTDs, is the re-entry of dengue fever as a major pandemic on our continent. When I was a couple of years ago, when we were doing research in the coastal area, maybe 5-7 years ago, we would have a few cases of dengue fever, but never anything that we're seeing now with cases even now being recognized in much higher altitude. It's now also, as you know, a disease that has spread even to some cities in the US, in some cities in South America, in some places in south of France, all because the climate change and especially the warming has allowed specifically the vectors for this disease to spread in those new areas. So in general, I think one of the things we must address is how then we engage policymakers to be able to understand how this is going to affect our policies and our plans on the elimination of these diseases. Because we eliminate them we can eliminate them in the areas that traditionally we know they were there. But then how about the new areas in which we are discovering these pathogens and these new diseases? Secondly, we must continually engage the communities to make them aware about these new changes in the epidemiology of these diseases as they change over time, so that they become aware that a few years back, we were not at risk of getting Kalaza. Now, because of climate change, we are at risk. What measures must we take as communities? And then as researchers, then we must put in place measures for surveillance to be able to go ahead of the game and warn policymakers and stakeholders that with the climate change happening, we're likely to be at danger of having outbreaks in these new areas. So those are some of the paradigm shifts that we must be aware of. I hope that answers most of the questions.
Thank you. I think very clear that we cannot, it cannot be the normal status quo, you know. We have to think about how do we address some of these issues if we are to achieve elimination. And I think you brought out a very crucial point. One of them is just awareness creation to make sure that some of these issues are considered, because they do hamper access and they do hamper the steps that need to be taken to reach our target of elimination. So thank you for clarifying that. And this is a consideration that should be made by all stakeholders. Yeah. One final question to our speakers before we move on to the question from the people who are listening, who have joined us. And so this question is to Simon. 2 or 3 points that we need to take into account if we are to think about achieving elimination. You spoke about issues of supply chain, and I was also just looking at some of the questions from the chat here, and one of them was about just access to these treatments. You know, that it's very it comes and goes. It's very sporadic, you know. And how do we resolve some of these issues to achieve elimination? So just from your point of view, what are the 2 or 3 points and the issues that we need to take into account if we are to achieve elimination? Yeah.
Thank you for that question. Before I go into my 2 or 3 points, allow me to just take a step back and mention a few other points that I think are very important. One, that it has been done. So 50 countries have eliminated at least one NTD in Africa. So it means this is possible. You mentioned earlier about WHO taking leadership in the elimination of leishmaniasis, and I would want to use leishmaniasis as an example. So early last year, WHO brought in partners together, and we were able to craft a strategy around elimination of leishmaniasis. And as a public health problem, meaning achieving less than 1% case fatality rate due to primary Kala-Azar. The other targets outlined in this strategy include 90% reduction in disease burden, 90% reduction in duration between the onset of symptoms and treatment to less than 30 days. And then lastly, 100% reduction in child mortality. Now, the strategy has 5 key elements. The main one which I would want to dwell on is early detection and then treatment. And this really speaks to what you're talking about, which is supply chain. And in supply chain, you talk about procurement and then the whole first mile and last mile delivery to the patient. So it is important that we are able to unlock sustainable financing mechanisms for us to be able to achieve elimination, because this is what is key in financing the elimination strategy, but most importantly, being able to procure the much needed commodities for treating the patients. Obviously, that means that we need to move from donorship to ownership, and then country ownership is really very, very key. And country ownership, I think Prof has kindly alluded to it in three various levels. So one, government level, which government leadership is very, very important. We expect that our government should offer leadership in coordinating the efforts towards the elimination of the disease. And you're talking about elimination in 8 countries within the region for visceral leishmaniasis. At implementation level, and then finally also at community level, where creation of awareness is very key. But specifically on supply chain, we are looking at various options, including having regional mechanisms to be able to deal with the supply chain issues. So for me to just give an example, currently what happens is all our commodities are procured through the WHO mechanism, and they are stored in Bordeaux in France, which are then from there transferred or transported to the various country WHO offices, then transfers the same to the Ministries of Health for onward last mile distribution to the health center. So it's such a long process that sometimes whenever we have outbreaks or stock rupture, it takes a long time for commodities to be transported from Bordeaux all the way to the countries. So we are championing together with the countries to have a regional kind of warehouse mechanism where, say, 25% of the commodities needed are stored locally and can easily be moved from one country to another whenever there is need, instead of waiting for the long process. And most importantly, also incorporating the last mile distribution of our commodities in the national supply chain. Currently, we are using a parallel system where the Ministry of Health either uses partners in distributing the commodities to the last mile. Yet, I think each and every country has a national supply chain that works, that if we integrate into, hopefully then we can be able to get these commodities faster to the patients. And finally, creating awareness at all levels so that at policy level, we are able to accelerate the adoption of the new treatments very quickly into the treatment guidelines so that patients can be able to benefit from them, and also at various levels so that there is more awareness and there is more support for the neglected tropical diseases. Thank you.
Thank you for that great response. I think what has really stood out for me is just the issue of country ownership, calling upon us to own the response to these neglected diseases. 40% of neglected diseases are found in the African region. And so as Africa, and when we are thinking about the new public health order and those sorts of things, we need to come to a place of owning the response to these diseases. So thank you for that. Very, 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 very good points from our speakers. And now we really want to move on to some of the questions. There's been lots and lots of questions on the chat, and some of them are very specific to what DNDi is doing here and why MSF is not here. Some of those questions we can leave for direct response from the various teams, but we want there are a few specific questions that we'd like to respond to. And the first question I would like to address to Professor Sam, which is, how do research and development efforts contribute to the improvement of treatments for neglected tropical diseases? That is a question that has been asked, and I would like Sam to address that.
Yeah, thank you very much for that question. Yes, R&D is very, very key to develop new molecules for neglected tropical diseases. And for DNDi, that has been our mission actually since we were established in 2003. And just for the record, since establishment, we have delivered 12 new treatments for 6 of the most devastating NTDs. So if you know really the very chain involved in ensuring that we deliver a molecule for treatment, it's a long process. So delivering 12 is a big deal for us. And we celebrated 20 years last year in November. And we're proud that we have been able to do that much. But going forward, it's very crucial that we are able to engage stakeholders and partners who fund us and new partners who may wish to be with us in ensuring that we look for new molecules. Therefore, R&D is a very important stream of our work. First, of course, is to look for molecules that can be able to work, of course, against neglected tropical diseases, for which very few organizations are working on. Not one single organization can be able to do this because, as you know, these are not diseases that would otherwise give incentive for the usual pharmaceutical companies to develop new products, because they would sell to who? These are not patients who can be able to afford these treatments. So there's no incentive for pharmaceutical industry to develop new products for these diseases. So we must then go out of our way to ensure that R&D is well funded, and that at the same time that these new treatments are less toxic than the ones that were there before. Because those of you who may have read a bit of history about Kala-Azar, about leishmaniasis in general, but also about other diseases, including, for example, dengue fever, schistosomiasis, and so on, the initial treatments that were available are very toxic. Now, we want to move away from that to treatments that are safe and efficacious, and at the same time, easy to deliver to communities that are neglected. So going forward, R&D must be strengthened by partnering and owning this problem, so that it's not just about funders or donors giving us R&D funding, but even our own governments and our own policymakers owning this problem and investing in R&D for our own populations. So that way, we'll be able to integrate NTDs into the normal public health problems that we face. And I'll give an instance here. Our governments are currently rolling out universal health coverage. We are in negotiation with most of the governments now to include NTDs as part and parcel of the rollout for UHC, so that as they, of course, provide funding and be able to, of course, roll out treatments for other diseases, they don't forget NTDs. And we want to do that, partnering also with the healthcare workers that are down there with the neglected populations, for them to understand why must we include NTDs with the rest of the universal health coverage as a package. That way, we'll not forget NTDs in terms of R&D, but also in terms of delivery. Back to you, Lynette.
Thank you. Very strong points there, especially about integration of R&D and integration of NTDs into the government programs. I think that's how ownership can happen. And so we have to really raise a voice and make this visible amongst our government stakeholders, so that they can include this in their normal programs, so that the people who are affected by NTDs are no longer left voiceless, but they can actually feel empowered and receive the treatments that they deserve. And also just that value of R&D and innovation in terms of responding to NTDs and leading to elimination. Very strong points there. The second question I would like for Marguerite to address. Someone was asking, I wanted to know the effectiveness of the regional program of MSF to eradicate various NTDs in the eastern part of Africa. So over to you, Marguerite, to respond to that question.
Well, it's a very wide question. There's a long list of neglected tropical diseases, and MSF has chosen the ones that are difficult to manage clinically. Some of you may know that there's many neglected tropical diseases that can be prevented with single treatments, like, for example, all the helminthic diseases, trachoma, other diseases, they're more easy to manage. The most neglected tropical diseases are those that require extended hospital care, complex diagnostic algorithms. So those are the ones that MSF chose to focus on. And one of these is Kala-Azar that we have been talking about. Another one is snake bites that we haven't mentioned yet, but it forms a huge public health burden and there's very little access to treatment. So we are also active there. Then there is other forms of leishmaniasis in countries outside of Africa that we have invested in a lot, the cutaneous forms. And then there is a disease called NOMA, which has only been recently admitted to the neglected tropical diseases list. And hopefully that will mean there will be more funding for this disease. It's a disease that affects mainly children. It's a devastating disease. It's a bacterial infection of the mouth, starting with gingivitis and then progressing really fast to facial deformity and death. So snake bites and NOMA are not listed for elimination by WHO because at this point that is completely not feasible. They are listed for better control, but Kala-Azar is now being listed for elimination. I think the way that MSF is contributing, as I think I mentioned before, is that our main capacity is to increase access to treatment. We can go to locations where a few other organizations can go, and where sometimes even governments are not able to provide access to care. So by doing that, we are already reducing the burden and therefore reducing transmission. And we have also seen some examples of locations where we've treated many patients, that the numbers of patients go down, because you will be, in the case of Kala-Azar, you will be left with a group of people who are either they have had the disease, they're treated and they recovered, or they have natural immunity. So after treatment, you also get natural immunity. So in that way, just by creating better access to treatment, you already contribute a lot to elimination. I hope that answers the question.
I'm sure there's thank you for that. I'm sure there's a lot that MSF is doing in relation to that, and you've really tried to summarize it. And so thanks for that. So one other question that I would like to address to Simon is what role do partnerships between governments, NGOs, pharmaceutical companies play in combating NTDs? I think this is a very important question, and just the Leishmaniasis East Africa platform by DNDi is one of an example of how partnership can work. So over to you, Simon.
Yeah, thank you. Actually, you've already answered the question by mentioning LEAP platform. It's a classical example of how partnership can help in controlling and eliminating the disease. So in LEAP platform, for example, we have policymakers from the government side, we have academia, we have institutions such as MSF, DNDi, and then sometimes even the private sector who come together. And then at the LEAP platform, what we do is we try to facilitate clinical testing of new treatment, but at the same time also engage in access activities. So what this has happened is that by bringing together the partners way ahead of time from inception of any given project, makes it easy at the tail end of that project for acceptability in terms of, for example, the policy change process. When we bring in the policy makers at the beginning of any project, then it makes it very easy at the end to ensure that these are adopted as fast as possible. Also trying to bring in the private sector, pharmaceutical companies, in understanding what are the challenges that you're faced with, helps in negotiating better procurement terms for the commodities, which ultimately is passed on to the patients. So that partnership is very, very key in the elimination of NTDs. Thank you.
Thank you, Simon. I think, yeah, just that cruciality of partners playing different roles is very, very important for the elimination of NTD. So at this point, just calling all partners. I know there's a lot of need, and I can see that in the chat where we're being asked a lot, you know, why aren't you here? Where are you here? You know, can you come and treat here? So there's a lot of need, and for us to be able to reach to all these different groups, then we really need partnerships and people to be involved. I think we might have time for one last question, and I'd like maybe Sam to address that particular question, which is what systemic barriers and structural inequalities perpetuate the cycle of neglect for diseases primarily affecting marginalized communities, and how can we effectively address these underlying issues? So over to you, Sam.
Yeah, very, very crucial question from that member of this audience. I think a major point here is that NTDs really, as we know them, are diseases of poverty. That's one. And for that matter, then there are also diseases of neglected populations. Now, if you take that combination, it means that if we were to elevate the socioeconomic status of these communities and raise awareness so that they become empowered, first by gaining a voice about their status, but secondly also become empowered to be able to live a better livelihood, especially being able to be aware and maybe changing, for example, their lifestyle in terms of being vulnerable to vectors that transmit these diseases. That is a starting point. But the bottom line is, if we can move these whole populations that are neglected to the next level, as enhanced socioeconomic status, coupled, of course, with improved sanitation, improved vector control, and improved nutrition, because nutrition also plays a key role in building immunity against these diseases. And again, you've got these populations, most of them are poor. Sometimes they don't have adequate food and nutritious food to build the immunity, not just against NTDs, but in general. You find these same populations also suffer from neglect of other diseases, infectious diseases, in the same area. So we're looking at a population that requires very, very active interventions in terms of socioeconomic empowerment and awareness and education in general, so that they become aware about their surrounding and what affects them and how they can move out of that by building resilience in those communities. So going forward, we are engaging community leaders, we are engaging governments, especially local governments, to ensure that there is investment in this ecosystem, in these places where we have NTDs. With those investments, people can get jobs and earn a living and become exposed generally to issues that elevate them away from abject poverty and also vulnerability against NTDs. Yeah, back to you, Lynette.
Thank you. I think just that giving NTD a context that there are other issues that have to be considered when you're talking about people suffering from neglected diseases. I think it's very important. And thank you for just responding to that. So I think this sort of brings the discussion to an end. We want to close it there. I wish we had more time to even discuss further, because there's so many different issues and a need for different collaborations and partnerships. And just to summarize what has come from this particular discussion, one of the things that I've just spoken about is the issue of partnerships and how important and crucial partnerships are for us to address and move on towards elimination. I think it's very, very crucial for partners to come from various parts of the world. And so we are calling on all partners who are here and other partners outside there to join the fight against the neglect, to end the neglect, to beat NTDs and to end NTDs. It's possible. And so we call on all our partners. The other discussion that has come is for us to eliminate, we do need funding. And I think Marguerite brought this very clearly, that we need to reach the last mile when it comes to innovation and access and all these activities. And so we need support from donors to be able to accomplish this. We also need awareness creation. I think there hasn't been adequate awareness creation at all levels, and therefore we need to raise awareness. And this calls, all media, other like-minded stakeholders to join us and raise awareness on the neglect of neglected diseases. And we need finally integration of the NTD program, R&D, into the normal programs of the government, thus country ownership, for us to be able to accomplish and eliminate this disease. I have been informed that there are some journalists in our midst and who would like follow-ups to the speakers, and therefore I would like to put the 2 emails in the chat that you can reach out to. One is from MSF and the other is from DNDi. If you want to speak to either Simon or Sam, please reach out to the DNDi email. If you'd like to speak to Marguerite, please reach out to the MSF email, and they can be able to link you to the right person, or to link you to whoever you need to speak to, so that then you can conduct your interviews. Remember, if you want to post about this conversation, please do it on the social media, tag DNDi, tag MSF Eastern Africa, and the hashtags are, as we close, beat NTDs, end NTDs, end the neglect. So I think we close there, unless there is any more housekeeping. I think this is just maybe for recording sake, there's some answered. I don't know if these questions can be recorded and we could reach out directly. There are quite a number of them, and some are very specific to the institutions. And so I think it will be good to maybe follow up some of these questions. So maybe as we conclude, one final sentence from each of our speakers to just close up the session. So maybe starting with Marguerite, one final sentence from you, and then, go.
Thank you, Lynette. Thank you, everybody, for such an active participation and for asking so many very important and relevant questions. I hope we can clarify more in a later stage, but just to know that as MSF, we are always very committed to work for the most neglected people in the most neglected areas or communities. Thank you.
Thank you so much, Marguerite. Simon, one final statement from you.
Again, just to stress what I've mentioned insofar as NTD elimination is concerned, like I mentioned, 50 countries all over the world have been able to eliminate at least one, 21 of them being in Africa. So it is possible. Cross-border collaboration is very, very key. Country ownership, like I've mentioned, and most importantly, domestic financing is important for us to be able to achieve this. So it is possible. Let's put all our hands together to fight and eliminate these diseases. Thank you.
Thank you. And finally, Sam.
And then the other part, yes,
mine is to state clearly that the business of management, control, and final elimination of NTDs is a business for all of us. Each one of us has a role to play, one way or the other. If you reflect, there must be something that you can contribute to in ensuring that we alleviate the suffering of these very, very poor populations, doing one thing or another. So let's take it upon ourselves to do that. Thank you.
Thank you, and thank you to all our great speakers. Thank you for all who joined us, and see you next time.